Hello, everyone. I'm very excited to present as part of this What's New in Pain session today. And as we all well know, pain is complex. Frustratingly, but wonderfully complex. And I say frustrating because, of course, it can be really difficult to understand why things continue to hurt. But wonderfully complex because if we start to understand the myriad of factors that contribute to why things hurt, we also have lots of different things that we can target in treatment. And so that's what my talk is going to focus on today, is targeting pain from many angles, and specifically exploring some of the new research findings that look into the importance of language, as well as a little bit of the work that myself and others have done in the area of sensory modulation. And then last, end off with a little bit of brain trickery. So before we begin, I'd like you to do something for me. I want you to imagine standing still. Now imagine seeing someone bigger than you that's running towards you. Imagine seeing them jump, tackle you, take you to the ground, and land right on top of you. How much would that hurt? I would think quite a lot. I would be expecting, some broken bone somewhere as I reach out with an outstretched arm, but it would hurt. And yet, why doesn't this hurt? We see this all the time in sports, don't we? A sports team celebrating a big moment and everyone running towards the player and piling on top of them, landing on top and essentially covering them. And yet they do this all the time and they come out uninjured. And to me, this highlights pain and its frustrating but wonderful complexity and shows the incredible importance of context. Because it matters if someone is coming towards you and you don't know them versus they're your teammates. It matters if they have a big smile on their face and you just did, whatever you did in the game. So you won, you got a goal, you hit a home run. That matters. Let me give you another example. So the environment around you, the context in the environment can contribute to pain. So this is a study where they were actually looking at something called the nociceptive withdrawal reflex. This is the reflex that if you touch something really hot, you automatically pull your hand back, almost even before you feel that burning pain. So in the study, they were measuring how big this reflex was, its magnitude. But what they were doing is they were testing the effect of different smells in the environment. So at baseline, this is about how big that nociceptive withdrawal reflex was. If they wafted in a nice pleasant smell or even just a neutral smell, the size of that reflex didn't change very much. However, if they waft in a smell of a terrible stinky fart, this is what happens to that reflex. It's upregulated. The magnitude of that reflex is bigger. And if you think about that, that's amazing. A smell in the environment is able to change the threat and protective reflexes and responses of our body. And what's quite interesting is not only were these protective reflexes influenced, but so was the pain experience itself. So when they were asked to rate how painful the electrical zap was, and this was the zap they used to elicit the reflex, at baseline it was about 4.4 out of 10. But if you had a nice smell, it reduced to about 2.5 out of 10. And despite being the exact same electrical stimuli, if there was a stinky smell, that increased to about 6.7 out of 10. So what this suggests is that we have a dynamic system that adapts and updates based upon the available information for that person, in that environment, and in that society. And so what it really becomes about is, what does the available information tell me about safety? What does the available information tell me about danger? And based on this balance of safety and danger, do I need to be protected? And if I do, then an output of pain is generated. But what becomes then really interesting is that considering these safety and danger cues and their balance can be really important when we think about treatment. And that comes to our new and exciting pain finding number 1. And that's that our words matter much more than we might think. Because if we go back to some of the experimental type studies, words themselves can alter the experience of pain. So in this study, what they had people do was read different sentences. And while they read these sentences, they received a hot, painful, burning probe on their skin, and they had to rate how painful that felt. And they received 2 different types of sentences. The first was a literal sentence. So Anna spilled acid on her hands, it felt burning. So it's related to what's happening to your body. But then they controlled for this by doing what's called a metaphoric sentence. So using the exact same word, but changing the context. So Eric's team lost 0 to 4. The defeat was burning. And they compared what happened to how much pain people felt. And they compared both people who had chronic pain and people who did not. And what they found was this, is when the metaphoric sentences were read, there was an increase in the pain that they felt. So that hot stimuli hurt more, but it didn't differ between the groups. But when you use the literal sentence, so it felt burning when you spilled acid on her hands, what happened is there was an increase in the pain that they felt, and that was heightened the most in people who had chronic pain. So there's this overprotective system when words are being told or said that have danger cues associated to them, all of a sudden pain increases. And it's even more than that. It's not just us reading sentences. What we're told about our body influences the pain that we feel. So this is a study that they were zapping people on the skin with a laser, so it hurts. But what they did first is they actually did a skin assessment on them, but this was completely fake. And in the assessment, what they did is they told them that different parts of their skin, it was safe for them to receive laser. But other parts, actually, it wasn't safe at all to receive laser, or, oh, it might be okay, but we're going to be careful. It's approved with reservations. And then what they did is they compared how much a laser zap in these different areas hurt. And what they found was this, is when the laser zap was applied in that area of skin that they said, oh, look, it's only approved with reservations, that same laser zap hurt significantly more than when it was given to those areas of skin that they were told were safe. And remember, it's a completely fake skin assessment. And this appeared to be driven by the anxiety that was induced by worrying about whether or not something like this was safe. But what it shows us is that things hurt more when you aren't sure that they're safe. And what's interesting is here we have a person in a lab coat that is a source of credible evidence. And if we think about the average person who has chronic pain, as clinicians, we're that credible source of evidence. And every clinical encounter, we have the ability to either add to the safety cues or to add to the danger cues for that person. So let's think about this perhaps in terms of scans, and specifically in the case of someone with osteoarthritis. So here's a typical scan that you will often see, and this is a scan of someone who has knee osteoarthritis. So we see loss of joint space, what we might expect. But often the things that they hear or are told when they see this scan are things like this: bone on bone, degeneration, wear and tear. You've got the knee of an 80-year-old, which is like awesome if they're 95, but kind of not as much of a compliment if they're 50. This is the worst x-ray I've ever seen. Your joints wear out as you get older. Better get used to it. This will be here for the rest of your life. And all of these things have a message that, you know, your joints are stuffed. It'll just get worse. You better be careful how much you do. And the trouble with this is that it's not supported by recent pain science research. So first of all, if we take people who do not have any knee pain at all and we chuck them into an MRI scanner, 2 in 5 of them over the age of 40 will have evidence of osteoarthritic changes on that scan, but they have no knee pain whatsoever. So when we see something like this, what we actually want to be saying is, these scan changes, they're about what I would expect. You can kind of think of these a little bit like wrinkles, because lots of these changes, we see them naturally as people age, but they're not always related to pain. But what's critical about this is they do not determine what you're capable of. So, for example, if we look into the literature, people that have very severe osteoarthritic changes on scans, it, first of all, doesn't always correlate with their pain levels, but also they still do really well with treatments like exercise. But what's also important, and a positive message that will be imbuing safety cues rather than danger cues, is this idea that we're all bioplastic. And what that means is that our systems can always adapt and change right up until the very end. Nothing's static. It's not your joints are going to wear out as you get older and you're not going to be able to do things. It's that your body continues to adapt even when you are aging and getting older. But it also has relevance, I think, to consider safety and danger cues in terms of how we talk about exercise. So in this case, we might say things like, stop if you feel any pain. Your jogging days are over. Be very careful when you do that movement. And again, we give this message that, movement is bad and it could injure you further, giving danger cues. When in fact, that's again, not what the evidence supports. It's that, movement might be painful at first, a bit like a sprained ankle, but it will get better as you get active. Safety cue. Or, our tissues adapt best through loading. Things like cartilage, it needs loading to get nutrients. It's the best thing you could do, slowly increasing your walking. That's exactly what you should be doing. Or your knee is strong and robust. Let's take it out for a test drive. All of these things that are imbuing safety messages. Now, of course, it's important that we update, I think, as clinicians, how we talk about pain, how we talk about scan findings. But for anyone who's listening who might have chronic pain in part of their body, it's also really important that to think and reflect about how you speak about your own body. Do we call it the bad knee or, my bad back, it's so weak? Those things matter. Words matter even when they're what you're saying about yourself. So I would suggest that that's something that is really important that we look into in terms of treatment. Now, the new and exciting pain finding number 2 is this. It's this idea that we have, all of us have, innate processes exist that actually link together sensory information about the body. And these innate processes can influence our perceptions, like pain. So when I'm talking about this, I'm really talking about this idea of sensory modulation. And it's this idea that information from one sensory source, so let's say vision, can modulate or change information from another sensory source, like touch, and ultimately change what you perceive or what you experience. So for example, in past experimental studies, there's evidence to suggest that having vision of our body and the size that we see our body actually influences how much pain we feel. And I was intrigued to see, okay, does this type of experimental finding that we see in people without any pain, does it apply to people that do have chronic pain? And so I tested it in people with painful knee osteoarthritis. And to test this, what I wanted to do is change the perceived size of their knee joint. And I used this technology called mediated reality. And what it does is it's real-time video, but it changes in front of your eyes. So because it's a video of your own knee and you watch it change, it's really quite compelling. So what I tested in this study was various illusions, but particularly this one called the stretch illusion, where you make the knee look big and long. So I'm going to show you a video. The video is basically as if your leg is stuck out straight in front of you and you're looking down at the top of your knee, at the kneecap. So here we go. and it's going to start to move. You're going to see in a moment, it starts to visually elongate. And as that happens, we pull on the calf muscle towards the foot at the exact same time. And this gives your brain credible, believable evidence that that leg, your knee, is actually changing in size. So what we did is had a bunch of different people who had painful knee osteoarthritis and gave them this illusion and lots of other different control conditions in a randomized order. And we didn't tell them which one the real illusion was, the one that we cared about. And this is what we found, is that when we gave them the real illusion, they had a significant reduction in the pain that they felt in their knee. But what was really important was that that pain reduction didn't occur if we just pulled on their knee, and it did not occur if we just visually changed the size of their knee. It required having both that vision and pull input that gave a really compelling sense that the knee changed size. And what was quite interesting is that we saw enhanced effects on pain when we repeated those illusions. Now, to me, what this says is actually it gives us this evidence that these innate sensory processes between, or these innate processes between vision and the pain that people feel, they seem to be intact and working okay in people with osteoarthritis, which that's really exciting. And one of the cool things that happened with this study is there was one fellow who had symptoms in his knee of intermittent swelling. And when we were doing these illusions, as we were doing them, what we noticed is his knee started to swell up. And that was interesting. So he was very kind and agreed to come back and let us test him a little bit more. But we explored what the effects of these illusions were on his knee swelling. So what we did is in those areas of the X on his leg, we measured the circumference of his leg to look at swelling. And what you can see here is that that dark bar is basically looking at the baseline condition of the circumference of his limb. And then this the stripedy bar is when we repeated the stretch illusion numerous times. And what you can see is that in this case, you had an increase in swelling. Then that clear bar is what we did is we stretched out his knee and then we just sustained that stretch position. So he looked at his knee while it stayed stretched out, and we had an even bigger increase in swelling. And then I didn't really want to send him home with a very swollen knee. So we tried some other things and particularly tried shrinking his whole leg. And as he continued to watch that, his swelling returned down back to near normal. Now, honestly, I was like, I don't know if I believe this. I need to check this out again. And he came back another day and we replicated those findings. So an increase in swelling when we repeated that stretch illusion and a decrease in swelling when we made his leg look small. But that's so interesting because it suggests that these innate processes between vision and other body parts and in your body, they actually have an effect on the physiological regulation of it, of the swelling. So in recent work that we've done, we've followed this up a little bit by saying, is it possible that some of these illusions might have an effect that is a little bit more complex than just changing size? Like, what if we gave people this really strong back? What if we push to see how far this link between vision and pain goes? And so what we were testing is, would giving people a really strong looking back while they were doing a lifting task, would that affect their pain? And would it affect actually like how comfortable they felt when they were lifting? And so we just tried this in a case study. And this was a person who had impaired perception of his back. So he kind of had trouble knowing where it was and things like that. But we had him undertake these illusions. And this is what we found is when he was experiencing these illusions while doing this lifting task, the blue bars are that strong, big, muscly condition. When his back looked and felt strong to him, he had reduced pain intensity while doing that lifting, reductions in how fearful he was. And he also reported that he felt stronger and felt also more confident in doing that lift. And so it raises this possibility that actually we might be able to influence a little bit more complex things that relate to how well you feel that your body is equipped to do different tasks. Now, we've also started to explore, I guess, the role that color might play And this comes from this idea that experimental studies have shown that giving someone a blue light before they get a painful stimuli on their hand actually makes that painful stimuli hurt less than if you shine a red light. So we recently tested this idea of blue in people that have something called burning mouth syndrome. And this is a syndrome, it's quite rare, but it results in this burning sensation, usually in the tongue and the oral mucosa. And what we found was that we used a similar setup as we did before. So they see a real-time video of their tongue, and then that's what they see on the screen in front of them. And we color inverted it, so we made it blue. And it was intriguing because what we found is this is data from 9 different patients, and the dark line is the average, but there was a significant reduction in the pain that they felt when they saw their tongue being blue. The burning pain reduced. So again, it suggests that these innate processes that seem to link together color and pain also seem to be working in people that have this relatively rare condition that is, not very amenable or responsive to treatment. So, and the other type of rare condition that we've looked at is in people that have phantom limb pain after an amputation. And using the same setup that I've talked about before, this augmented reality or mediated reality, we replaced their missing limb. So we took an image of their intact limb, we flipped it over and mirrored it on the other side. So now it looks like they have 2 limbs. And then what we did is we had them actually walk. And all we did was delay this video a little bit. So you then actually start to get this walking pattern. And this is what it looked like. So this is the same fellow who's sitting in the chair, and this is just showing what that illusion looked like to him. And what was quite intriguing is that he was able to move his phantom limb, actually, which is really interesting. And so when we had him do that walking condition, but not move his phantom limb, so what he's seeing doesn't match what he is feeling in his phantom limb, you can see here that his phantom limb pain, that's in the red, increased, as did the phantom limb pain is in blue, and then the tingling feelings are in red. But what's interesting is that when we got him to actually move his phantom limb in time with what he visually saw, that had a drastically different effect on his pain. So it reduced his phantom limb pain as well as almost all of his other phantom limb sensations. So again, even in these rare conditions, supporting this innate process and these innate links between vision and the resultant pain experience. And the last things that I want to share about sensory modulation actually relate to sound. And because we do know that sound information has quite strong links between what we feel, but also how we move. And I was interested in exploring the role of sound in people that have chronic back pain and stiffness, particularly because if you think of a stiff joint, it makes a lot of noise, doesn't it? It creaks, it groans, it cracks. And so I was interested in people who have back pain and stiffness. What would happen to how stiff their back felt if I pressed into their back and paired that with a creaky noise of a rusty gate? What would happen? This is what it looked like. Terrible sound, but that was paired with that pressure, this machine that's putting pressure into their back. And so what we did is we did that numerous times, pairing the sound, but we also gave them a control sound that sounded like a nice whoosh, whoosh, a little bit more ease of movement. And we looked at how stiff their back felt. So things on this graph, if it's up here, it's a correlate of feeling stiffer. If it's down here, it's feeling less stiff. And so when we paired that creaky sound with 3 different presses into their back, in both people with back pain and back stiffness and healthy controls, their back felt stiffer. But intriguingly, we see an almost opposite thing when we give that nice whoosh sound. Their back feels less stiff. So this is quite cool because the context and the meaning behind that sound seem to matter, but also it suggests that these links between sound and how your body feels, they seem to be intact again in people that have chronic back pain and stiffness. Now, the last thing that I want to raise is just recently, I worked on a review that was looking at the effect of sound on, body and movement perception. And this is free for anyone who wants to take a look at it. But it just showed that actually sound modulates so many different things, how our body feels to us, how surfaces feel when we touch it, how it feels when we move, how hard, how much effort we perceive we're putting in. And I think we really haven't used these to our advantage yet. So, for example, one of the studies looked at the effect of adding a sound to someone's performance, particularly a hammer thrower. So they were doing the hammer throw, and what they gave them was a rhythmic sound that was basically what it sounded like when the hammer went through the air. And they used the sound that was associated with their best personal throw. Now, when athletes had this sound, they threw further, but they also standardized their motor performance. And so I think this has huge potential for the ability to be applied in conditions of pain, but also maybe in assisting recovery after stroke, where we're using some of this auditory feedback to try to reinstate some of these systems. So taken together, well, this is a new area. I think it has huge potential, certainly to be added to different treatments that already exist, such as pairing with exercise, but also to explore the ways that we can use these to our advantage in treatment. Now, the last and new and exciting pain finding that I want to give you today relates to brain trickery, and particularly using brain trickery to develop new hypotheses about pain and its treatment. So what I actually want to talk to you today is about priming. Now, priming is a little bit like, it's like setting the stage or shaping your expectations. So if someone tells you, a movie's awesome, they've primed you to expect it to be awesome. And sometimes it's hard because then even if it's really good, it doesn't quite meet that standard because you were expecting it to be so good. But this can have this effective priming can actually not only influence expectations, but it can literally influence what we experience, what we perceive. Now, I'm going to show you a video. And in this video, that there's a girl standing there and a word is going to come up on her on the left-hand side of your screen. What I want you to do is read the word to yourself and then listen to what you hear. Now read the word on the other side. Let's try it. Brainstorm. Green needle. So the crazy thing is you will only hear the word that you are reading or saying, despite the fact that that audio file is exactly the same. And what's really interesting is that type of priming, it actually appears to extend to things like performance. So in this study, what they were doing is getting people to do a counting task. And what they did is they split people into two groups. And in one group, they said, actually, pain disturbs cognitive processes like visual processing and memory, things you will use in this task. And then they had those same participants do the task once while they were receiving something painful and once when they weren't, and looked at how well they performed. And what they found was this, is that when they were in pain, this negative group who had been primed to expect pain would hinder performance, they did perform worse on the task when they had pain than when they didn't. But what was intriguing is there was a positive group where they were told pain enhances cognitive processes like visual processing and memory. And what was intriguing is they had the exact opposite results. When they were primed with information that pain helps performance, they performed better when they were in pain than when they weren't. And to me, this just raises the possibility of, if we understand things like this better, how can we enhance these effects of priming? What pictures do we have up in our clinic? Are they really ugly, bad pictures of a bulging disc? Or do we have things in place that help prime And the way that we speak and the way that we describe influences of exercise, can we positively prime and help these natural processes take over? So in summary today, what I'd like you to take away from my talk is really that pain is protective. And the balance between safety and danger cues determines that need to protect and whether or not we feel pain. And as such, our words matter. Are we giving safety cues or are we giving danger cues? There are also many innate sensory modulatory systems in place that seem to still be intact in people that have chronic pain and other chronic conditions. Can we use these to our advantage? And last, Brain Trickery, I think, provides some really cool and unique hypotheses about pain and is relevant to look at to help us direct future treatment. Thank you for your time. And I'd just like to thank the following people that I work with here at UniSA and at my other collaborators. Thank you so much.